Next up, we have Solange Ngala from the University of Utah.
All right. Good afternoon, everybody. Can we answer like people who are happy to be here today? Good afternoon. Great. I just want to take this opportunity to say thank you to these wonderful organizers for this great project that you've realized. If you are here up to now, I think we all can bear witnesses that this has been a very wonderful time. And to all our keynote speakers, our poster presenters, and to you all for being here this afternoon. I think you are just so wonderful. I'm Solange Ngala, as we just heard. I'm a public health specialist, and I'm working presently on a research as a community expert with the University of Utah. Every year, greater than 10 million people develop tuberculosis, among which more than 1.5 million people die, making tuberculosis the highest deadly disease even before COVID-19. And among people living with HIV, the risk of developing tuberculosis is 20 to 30 times higher, especially in high-burden settings. Most global estimates treat adults as one group and children as another. But what happens within those age bands? How does HIV affect TB outcomes in children, adolescents, the young adults, and the older adults? Today, I'm going to be sharing with us some findings we had when we had to look at age-specific relationship between HIV and TB treatment outcomes in West Region of Cameroon. Someone is wondering where Cameroon is. Do we see this? All right, great. And we are going to know how what it tells us about tailoring care for specific age groups. Tuberculosis is actually an infection caused by Mycobacterium tuberculosis. And without treatment, our 10-year survival rate would just be about 50%. But if we follow the WHO recommendation for our treatment, we are sure that our cure rate can actually go up to 85%. The HIV burden has increased over the time significantly. The incidence rate keeps increasing as years go by. And someone might be asking themselves in this place, why talk about high burden settings when we are in the US? Even as we go along, I just want you to have in mind that we have California, we have Florida, we have which other two states that are already reporting the resurgence of tuberculosis. So if you think that is something that was far, as the world is becoming more and more a global village, this is not far from us. We had thought that we had eradicated tuberculosis in the US, but I will tell you that in 2023, cases are now coming up. And start asking yourself, I live in these places. I live in some of these states. This is no longer far. It is no longer an African country disease, as some people had always thought. It is now very close to us in here. All right. This, again, the African regions have the highest prevalence incidence and HIV-related deaths, both for HIV and tuberculosis. So again, that is a problem. And in this research, we wanted to move beyond just the knowledge that TB or HIV affects TB treatment outcomes. The main thing we wanted to find out, for whom, which population, who are those really affected by this? It is already established by WHO, CDC, from our past experiences, from other researchers, that HIV actually is a problem with TB patients. But then, who are those who are actually the main persons who suffer from this. TB and HIV have moved hand in hand for centuries. And majority of the new TB cases are actually associated with HIV. If you find a TB patient, there is that high probability. We are not saying it's a certainty. There is a high probability that they are going to be HIV positive. So, again, we need to always think about that. Until date, TB HIV remains one of the deadliest co-infectious disease pairing. Have you seen a kind of disease that, there's that kind of affinity? No one wants to leave the other. Once HIV is there, TB is like, I'm following you so closely. HIV is, please, I'm already in trouble. Can you just let me be? And TB is like, no, let's just move together. No one wants to leave the other. But again, we want to know that TB outcomes are not uniform across age or HIV status. Yeah, I just wanted us to look at the synergistic relationship and the fact that there is that difficulty. It is more challenging to treat or to deal with HIV and TB patients. Once you have the co-infection, it is more difficult for you to be managed, mostly because of what we call IRIS, immune reconstitution inflammatory syndrome. This is just a severe paradoxical worsening of TB symptoms when the immune system actually recovers, especially in patients after they started ART. Now, let me bring this down. Let's take, for example, our organizers were outside, right, while we are in here. And for some reason, they fell asleep. We have intruders. So some bad guys got into our midst and filled up some of these places. They had no idea. And then, let's say, 1 hour later, they realize that this hall is full. And they get up from sleep. On coming in here, there is that commotion. The bad guys are now trying to fight our organizers. There is that commotion. Oops. Right. So that fighting that is happening at that time is what is that's what is happening for those TB patients or in those co-infected patients, which makes them worse, which makes their symptom worse. So even when it seemed like they were their immune system was getting better, because of that co-infection, it is hard. The immune system is like, something is not right. There is that fight that is happening in, and most of these patients get worse. We don't want to see that. And if you look at my bio, there's something I'll always say: prevention is better than cure. We don't need to get to the level where we have to be fighting, where we need to be letting our immune system get to that level. But then, if it already happens, what do we do? Cameroon is representative of most, so again, so this is just from data 2012 to 2022. That is showing us the treatment outcomes for people diagnosed with new or relapsed episode of TB. So this is global data. And here you see new and relapsed TB cases. These are people who do not have HIV. If you look here, you will see their treatment success, which we are going to define soon, looks better than those who are co-infected. And you see the successful treatment outcomes here looking worse than those who have no HIV. Why this study? Why Cameroon? Now, Cameroon is representative of many high-burdened, resource-limited settings, which makes these findings not just relevant for one country. Again, it is getting closer than when it all began. So even though we know that it is a resource-limited country, it is also it's getting more real. It's getting more real even as the decades continue to increase. So we know that the results from here is not just going to be valid for one country, but it's something that is going to be used globally. And again, since we already know that HIV Since we already know from past research that HIV worsens TB outcomes, again, we wanted to move past that fact and ask, for whom is this worse? And we decided to work with programmatic data. Why did we go with programmatic data? So these are registers that treatment centers, that hospitals use in their daily activities. And it is just what ministries, the funders actually rely on for funding. So we had to go with some of these hospitals, and the choice of hospitals we went in with, let's say, the high volume structures, and they were mixed. So from government to private and to faith-based structures. These are the population that we have to work with. And we decided to define or to go with the WHO definitions. This is just so that to have a good comparability in what we're doing. And when we talk about successful treatment outcomes and unsuccessful, so successful will be those who were cured of tuberculosis or who had completed their treatment. There is a difference in that language when we talk about the definitions. And for those who were unsuccessful, there were those who had either failed treatment, those who had died, and definition of die again is a little bit strange in the TB world, and those who were lost to follow up. If you have any question, you could just interrupt and I explain that quickly. And we also looked at the turnaround time. Turnaround time is just the days from the TB test to when you begin your treatment. For our results, we actually saw that HIV status, age, and treatment year were significantly different in 2 treatment groups. We are going to talk more about that. And again, we had to look at association. So HIV age group interaction was significant. Success for 2019 was also one of the outcomes that we had, treatment success, which was higher. 2019, where are you? Was higher. And we looked at the HIV was associated with lower treatment success. Again, this is already a fact. We just confirmed again in this study because HIV, TB move hand in hand. And for this, so this is with the age groups, part of the results. So treatment success was lower for people living with HIV in the age groups 16 or greater than 16 years, and lowest for those not on ART. You have HIV, you are not on ART, you had worse treatment success. So your treatment outcomes were not desirable. And also we had a significant trend test in each of the groups, with those less than 40, the greater than 45-year-old having the worst treatment outcomes. That's telling us something. Now, we talked of this. I'm going to start from treatment year 2019. We've seen that we had, the success rate for 2019 was the highest, and we are saying here that this was consistent. The high rate was actually probably due to improved diagnostics. In 2019, we had more of Gene Expert. Do we know Gene Expert? Is there anyone who is familiar with that? So that's actually just a diagnostic tool for tuberculosis. Microscopy is actually the main tool that is used. And that is just all about producing sputum sample or whatever, and it is prepared in the lab and checked under the microscope. But then when we improved diagnostics, which we added other diagnostic tools like Gene Expert. Gene Expert is a molecular test. It improved quicker diagnosis, which in turn would lead to better treatment success, because the time to diagnostic is also going to be reduced. Also, HIV interaction and TB treatment outcomes. So we saw this, and we had reported that TB treatment outcome in HIV differed across these age bands. And again, with the greater than 45-year-old having the worst treatment success. And let me pause here to say this. So we went one time to the community to do some community work, and we met this old father who had 13 kids, 13 children, and he had symptoms of TB. Well, does anyone know the symptoms of tuberculosis? Anyone, at least, just one, a common one. Cough, at least. If we know nothing, we should know of cough. Cough, right? At first, we would say cough greater than or equal to 2 weeks, but it is no longer that bad. That width is too much. We talk about current cough. So if you have cough, you've lost weight unintentionally. I'm not talking about those who are doing their gym things here. We talk about weight loss, fever, and night sweats. Those are the main symptoms of tuberculosis. So this father actually had this, but because he had no way to find himself in the hospital, or he thought, well, it's just cough. That's what everyone says. It's just cough. It's never just cough. So after trying all the antibiotics he could think of in the community, nothing was going right until when we found him in the community. And what happened is we took his sample back to shall I say the town or something. And when we examined that sample, it was positive for tuberculosis. Now come to think of it, he lives with 13 other family members, other household members in one tight place. We've seen so many presenters talking about this. It's like I'm repeating what has been going on. Like it's just laying more emphasis. Look at that small space he finds himself. He is in in fact, an interior village. That's why he cannot even find himself. He doesn't have transportation, as we talked, one of the social determinants of health. He didn't have transportation. He doesn't even have what to feed, not to talk of thinking of coming right to town to do anything. When we took that sample and it was positive, it's a distance, I'll tell you. It's not just like we talk of community, maybe just going to no, I mean a good distance, a lot. When it was positive now, the time to go back to deliver that result was a problem. The time for him to begin treatment was a problem. And to make sure that he even goes through, because TB is not just like you can give all your dosage at the same time and say, okay, go manage it. No, there is that direct observed therapy. We need to see how it is going. Again, because we know that iris exists. What if your system is like, I can't do this anymore? Someone needs to be there to help you out, because the treatment, when you have iris, is a little bit much more uncomfortable. So someone needs to help you out. So all of this delay had their issues. Now come to think again, that father had 13 other children living with him. Okay. I said I was not going to talk about this because we already know that that's a fact. Let's come back to this. Early initiation of ART, public health implications. I'm coming back to the story of the father because it's going to touch most of these things here. We have this guy, he's in the community with a family. Many other people are suffering. They have no idea. The time to go back to this community is a problem, because who wants to just get up and leave their families to travel a day just to tell someone, oh, your results were not good and we need to start you a treatment on this. There is a problem just everywhere. When we succeeded to go back to that community, what happened? 6 of this man's children were also symptomatic. So they also had the symptoms for TB, and the samples were collected from them, taken back, because we can't do the diagnosis in the field. You will not really move with a microscope or the gene expert machine to every household to do this. And when we got those samples, 6 of these household members were infected, making a total of 7 people. And when we say infected, we are not even excluding the others, because they could have what we call latent TB. So the TB is in them, it's just that it's not yet active. And in those cases, they will always be negative when you want to do their diagnosis. So try to think of it. We are having delay in diagnosis. That's one problem. We have delay in treatment because if you don't diagnose them early, you are not going to treat them early. Again, this person is an older man. Then, all of this, when you look at all of this, try to put yourself in this man's shoes. You see that a lot is happening in the community out there. Everyone suffers from it. These kids go to schools, some of the schools that your children are in. They go to schools. That is how the bacteria keeps moving, keeps spreading. Because it just takes for us to be in this room enclosed, and I have TB, and I cough it out, and that direct contact is there. You have it. It might stay quiet in you. It might be latent in you for a very long period, even 10 years. Until when there is that opportunity, your immune system can become weakened for whatever reason. It might be HIV, it might be whatever reason. And then TB now says, oh, I now have that opportunity. Let me show up. At that time, managing it is very, very difficult. There was someone who was in mask the whole of yesterday and probably today. And in my mind, I was like, I like this idea. It's not easy, but... And I will tell you that at the time of COVID, it helped. You might be surprised, but the number of TB cases during the COVID-19 period, somehow we were able to see some patterns. And to us, we felt that it is because people were now not able to transmit the bacteria to others because of the face mask imposure or something. Again, there is a problem. The aged people actually suffer, the older people suffer more, and they had more undesirable treatment success. Reducing the diagnosis and treatment time will actually help this population of people. It will help them. If you can just reduce it, if you can do education, we are we know that we are actually going to have more desirable treatment outcomes. Also, early ART initiation. At first in Cameroon, what would happen is when you're HIV positive, your CD4 count needed to be very low before you are initiated on ART. It wasn't just that we loved it that way. That wasn't really the case. It's also because it's a resource-limited setting. Continue to think of that. It is a resource-limited setting. And imagine giving ART for everyone, you are at risk of drug shortages. And so you're like, well, let's wait until this person's immune system really degrades before we initiate ART. That's not really ideal. But again, because of the settings, that is what is going on. But fortunately, at this time, once you're diagnosed, once you are told you are HIV positive, you are just put on ART, which is actually helping because it keeps your immune system strong, just so that in case you have tuberculosis, you are not worried of iris. Do we get it? You are not so worried that you can develop the immune reconstitution inflammatory syndrome. We are not so worried of that. So you need to make sure we try to initiate ART early enough. Integration of TB HIV services. Again, this was a very big problem. TB and HIV, we've said that those are those twins that they're like, oh, I can't do without you. This one says, no, without you, I can't. How do you see a co-infection like this as strong as they want to move together and you think that you want to separate the services? While one service is in where? At the airport. Okay, that's the highest I know. One service is at the airport, the next is in Concord. At least I've visited those two places since yesterday. So that is not going to be it. Why? If we integrate these services, what is the advantage? Once you see an HIV patient that presents in front of you, what should come to your mind immediately? Who knows? Once you see the HIV patient in front of you, what should come to your mind immediately? They might have TB. So the very first thing for you to do is to screen them for tuberculosis. And vice versa. If you see someone presenting at your unit with tuberculosis, what should you think of? HIV. I need to screen this person for HIV. You don't treat them as separate services. Those are, again, very deadly co-infections. Has anyone ever seen a TB patient here? Oh, so many. Okay, that's great. If you see a typical TB patient who is really, really down, you would feel bad. You could see their ribs, actually. And it's unfortunate that some medical doctors think that TB does not exist. That is a myth. You might say I'm making this up. When I was controlling a particular region in Cameroon, I was doing a study, and it was mostly for children, so pediatrics. I went to this hospital, and this guy, the doctor, he was like, you know what? I've never seen TB before. I've never seen a TB patient. It doesn't exist. And in my mind, and he says he's been a doctor for 30 years. I asked him where he practices medicine. It was strange. First, he's an African. And if if it's maybe a Caucasian, I'll be like, well, an African man. Where did you study that you tell me TB doesn't exist? And this patient comes to the hospital, and guess what? He does everything. He does chest x-ray. He keeps excluding tuberculosis because he doesn't believe it exists. So I talked with him, when those heated debates come up. This day I saw that he was not easy to break through. So I came to him, I'm like, let's try this. It will be on me. So I said, I'm going to take whatever the outcome, it's going to be on me. There was so much back and forth. And at the end of the day, we agreed for him to begin that further on TB treatment. And we had to monitor, there is that fear on both ends, but my fear was far less because I could see that there was no need for him to start this patient on anti-TB. And guess what? After 2 weeks, this father started responding to treatment. And shamefully, the doctor called me to his hospital. He said, Doc, can you meet me? So he's a French-speaking doctor. He called and asked me if it was possible for me to come so we talk. In my mind, it clicked immediately that he's seeing results. And the good thing is, from that time on, he took this in fact, he took this, because he saw it was his patient. He saw that it was something that was happening. He had to make, in fact, all the therapeutic committee sessions in his hospital. He talked about it. We had several meetings with all the staff. That is just to tell us that these are things that are happening. And again, it is not far. It is not an African thing. It is here with us. And it's not going anywhere if we don't do anything about it. I'm talking to us because we are the ones who see the patients. Most people here, you see these patients. Talk to your physicians. Ask them, we've tried this. Have you thought of TB? Can we diagnose? Can we do this? Can we do chest x-ray? I don't know the diagnostic tool in your particular facilities. Can we do chest x-ray? Can they read the x-ray and see if this person has cavities? If we check all of this, then we are sure that we are actually going to help the population. And we have the strength and limitations of this study. The time is already gone. And to conclude, again, HIV and AIDS jointly worsen TB outcomes. We've just talked about the elderly greater than 45 years of age having worse treatment outcomes, and also older HIV positive adults, especially those not on ART. Remember, we are talking about the co-infected. Those not on ART represent a critical, underserved risk groups. and we need to think again and again on them. And I'll end by saying, integration without precision is not equity. Thank you. Any questions? Oh, there's a mic. Okay.
I think that is one of the best speakers of today. Thank you so much, Solange. So I was just thinking, I think I haven't spoken today or yesterday. So I was just thinking, throughout your research, did you identify any gender or difference in gender or socioeconomic status?
Perfect, great question. And I'm going to answer this very nicely because we've had so many studies on this. And we realized, and even in past studies, that the males were doing or had more unsuccessful treatment outcomes. And there were many reasons for this. Now, in high burden, resource limited settings, we know that the males actually are the ones who do most of the work out there. So what would happen is this. When a father, say in a household, when a father is sick, when he starts presenting the symptoms of TB, he doesn't want to go to the hospital. Why? He is the sole breadwinner. He's the sole person to provide for the family. He starts imagining, there's going to be hospital stay, because with TB, the first 2 weeks you need to be admitted in the hospital. You need to have that direct observed therapy. They need to watch you take those because they are very undesirable. So if you leave it to those patients, once they take it and the body starts doing some funny thing, what will happen? They will abandon it. So you want to be sure they are taking this. And you want to also make sure that you are reducing that bacteria load before they go out there and infect more people. Now, this person doesn't want to stay in the hospital. He wants to go and do his farming in some other region. All that time, that's how he's delaying his treatment. And then, by the time they are now, he can't walk any longer. That's when they are now maybe coming in an ambulance or to the, like some emergency is happening at that time, and that's when they're coming. And sometimes it is not, it's already late. It's somehow already late. So yes, the males were having worse treatment outcomes. Yes, please.
And the pneumonia that is associated with HIV?
Wow, thank you so much for that question. So, pneumonia, and just before I even say this, that's where the main problem even comes in with the interpretation of our chest x-rays. Pneumonia had always been, TB has always been confused with the presentation of pneumonia. So sometimes when patients come and they are actually TB positive, the doctor thinks that it is pneumonia. So again, there are specialized people that can read the chest x-ray, the films. I don't know, but they are the very specialized people that can actually read those films and say, oh, I see cavities. It is not pneumonia. I see that this is actually tuberculosis. With that question, I would not really be able to say there's any relationship. So pneumonia is actually, is separate. It's not really TB. Those are just two separate things that we are talking about here. Pneumonia is pneumonia with HIV, and then TB is TB with HIV, but we didn't find there's no relationship between you having pneumonia and then. It's just that, again, because it is something of the lungs, because your lungs are not doing well, what just happens is that as you get that weak immune system, you are that person who can actually get the tuberculosis infection. But it's not right, like there is a relationship between the two. I don't know if you get me. So there's no relationship per se, but if you have problems with your lungs already, then if I have TB and you have problem with your lungs and I cough or sing or talk, and if I had to compare you with some other person who didn't have any problem with the lungs, you with the problem should be at a greater risk than some other person who is perfectly or has a stronger immune system. Thank you. Thank you so much. All right, and my email is here. If you have any question, I'm very willing to give you answers. Thank you.